Hello, and welcome to this Practicing Clinicians Exchange podcast series on multiple sclerosis. This is the first of 3 podcasts, and today we will be focusing on the importance of early diagnosis and early treatment of MS. My name is Allison Boyd, and I'm a physician assistant specializing in MS at Sentara Neurology in Virginia Beach.
And hi, Allison. I'm Dr. Stephen Krieger, professor of neurology at the Icahn School of Medicine at Mount Sinai in New York.
This program is supported by an educational grant from Genentech. Partners for Advancing Clinical Education is providing this activity for 0.25 ANCC and AAPA credits, with 0.25 pharmacy credits available for nurse practitioners. To receive your credit for this program, please go to pce.is/ms. I'll repeat this link at the end of the discussion as well. Our learning objective for this podcast is to help clinicians use recommended strategies and establish a diagnosis of MS to facilitate early initiation of therapy. We'll share some practical strategies you can apply in your everyday work as a key part of our clinical care team. With that in mind, Stephen, I'd like to start by asking you your thoughts and insights of why it is so important to really catch MS and diagnose at the earliest stage.
MS is in many ways the disease in neurology that we've had the greatest success in being able to treat in these last 15 or 20 years. And because of that, there's a great motivation to try to arrive at a correct diagnosis as early as we can, because we know that if we invoke preventative therapies early, we do a better job of preventing disability. So, early diagnosis leads to early treatment. That's our goal. But it is challenging because, as everyone who takes care of people with MS knows, no 2 people with MS are quite the same. There's a lot of variability in how it can present. One person may have optic neuritis, someone else may have a brainstem episode, someone else may have symptoms from a spinal cord lesion, and these things all look quite different, which is where having McDonald criteria to establish a diagnosis is really important. It's where keeping in mind the variation in MS subtypes, relapsing remitting MS versus types that begin with progression, which is called primary progressive MS, is also really important. There's a tension between making an early diagnosis and not overdiagnosing MS. And that's a tension that Andrew Solomon in Vermont has written a lot about. How can we make the diagnosis accurately but not have misdiagnosis? And I think that's very important, as well as even once we have made the diagnosis of MS, taking into account which are favorable prognostic factors, which are more challenging prognostic factors. So in my mind, if a patient presents with new onset MS and she has a big lesion burden, has had weakness early on in her clinical course, such as the first attack with weakness, early bladder or bowel symptoms. Those are some of the clinical and imaging features with someone who has a lot of lesions that we would really be quite worried about. Allison, what do you think, coming at this from your perspective, what are some of the challenges in facilitating early diagnosis and getting people towards early treatment that you see in your practice?
I completely agree and will echo the variability in patient presentations. And that can be very daunting and overwhelming for somebody who is not familiar with MS, or coming from the primary care perspective, it can just become a lot to take in and really sort through with a patient in that 15-minute follow-up visit. Some of the very important factors would be for providers to be able to identify the patient population who will be developing MS. And I often will teach people that it's the young, healthy people who are often developing MS. So it's often easy to overlook some of the early signs and symptoms because also the classic presentation is symptoms come and go. So in a healthy young population, if symptoms go away and they weren't debilitating enough to get them to early evaluation, then they may be explained via, whatever seems most suspicious, or such as a pinched nerve, or I worked out too hard, or I'm chasing around kids all day. These can be things that are factors that delay patients from getting to us. once the early signs are detected by primary care, I think it's of utmost importance to have that kind of radar up and get them to a neurologist. More importantly, if available, an MS specialist. And we know that a lot of times it may be months before patients are able to get in with a specialist, let alone subspecialist. So really working to get them referred in a timely manner to not delay diagnosis and ultimately treatment. Assessing and addressing comorbidities is also very important so that we know that things that can sometimes look like MS or be mimics are being addressed fully. And then also that when patients get to us, we need that backup of the primary care team to manage the high blood pressure, high cholesterol, thyroid conditions, which can all influence the treatment of MS as well. Looking at the diagnosis, we know it's very complex. And I always tell patients that it is kind of putting the puzzle pieces together. There's no one specific test that 100% trumps everything and says this is the diagnosis. Dr. Krieger, what do you see as the most important tools and strategies to get a correct and quick diagnosis as much as possible?
Yeah, I appreciate everything you said. And you're right, there can be a long wait to get to see a neurologist, particularly a neurologist with MS expertise. But I do think there are also a lot of nurse practitioners and PAs like yourself who have real neurological expertise and MS expertise. So anyone with a background in MS doesn't have to be a neurologist, I think can be really instrumental in making that diagnosis. I mentioned the McDonald criteria and can seem sort of esoteric, but I want to try to make it really simple. I think that this is the most important way we can make sure that what we're looking at really invokes MS. So you said people can have symptoms they attributed to a pinched nerve or fatigue from normal life, but the McDonald criteria makes it clear that there are a particular set of symptoms that are highly MS suggestive. So I mentioned optic neuritis, loss of vision in one eye, lasting for days or sometimes longer. That should certainly get someone to medical attention to think about optic neuritis, particularly in a young adult. Numbness, tingling, or weakness can be signs of MS, but they are not usually fleeting or transient or positional, like it might be with a pinched nerve. Again, the demyelinating disease, inflammation in the central nervous system evolves over days, declares itself. And so we talk about MS relapses lasting for more than 24 hours. In truth, they really last much more than 24 hours, but that helps to distinguish transient things from those that suggest MS. What the McDonald criteria tries to do is say, what is sufficient to be sure that somebody has multiple sclerosis, even very early on? And MRI is the most useful tool for this. So someone who has a clinical picture, clinical symptoms that suggest MS, they should get MRI scans of the brain and of the spinal cord. Lesions in certain places in the brain are very suggestive of MS. Periventricular, that is, they touch the ventricle. Juxtacortical, that is, they touch the cortex. Infratentorial, so in the brain stem or the cerebellum. And finally, lesions in the spinal cord. Those are the four places that we really care about, and that helps to distinguish MS lesions from non-specific lesions that are not likely to be MS. And even when someone has MS, MRI is an important test we use for monitoring, looking for the lesion burden, making sure people don't have new lesions. So I try to counsel my patients that early in an MS diagnosis, they should have MRI scans probably once a year. So I mentioned things that are highly MS suggestive. I think it's also worth thinking about clinical symptoms that are not suggestive of MS, or red flags that maybe MS is not the right diagnosis. What red flags do you encounter in your practice, Allison?
I actually see these quite a bit because as we have discussed, sometimes it can be overwhelming when a patient comes in with a whole list of variable and coming and going, relapsing, remitting neurologic symptoms. And so we do get patients who will come in and they'll bring up symptoms and say, well, I Googled it. It says MS. And I have to counsel them that, yes, things can definitely overlap. But as you had said, we're looking for a specific presentation and a description of the symptoms. And that really helps us to tease out if it may be MS or maybe one of the common mimickers. Oftentimes, as you have mentioned, if it's a fleeting symptom lasting less than 24 hours, that is not really suggestive of something like MS. We're looking for longer presentation. I also will see patients who come in that you can pretty clearly identify that their symptoms are very broad, nonspecific, and they definitely would not be able to be traced back to a single lesion in the CNS. I will see oftentimes patients with fibromyalgia, sometimes teasing out the functional neurologic disorders can be very difficult because these patients often will just say, well, they want an answer. They want something to explain how they're feeling. And so it sometimes is very difficult to tell them you don't have MS. And as much as we think that would be a great conversation for a lot of patients, it still leaves so much unknown. A lot of times patients will come in with abnormal MRI, and I have to explain not all white spots are MS. We see, the white matter changes. We're looking for, again, very specific patterns, what they look like, changes over time. And I often will have to explain that, at the age of 60, with a long history of high blood pressure, high cholesterol, diabetes, and smoking, we have much more realistic understanding of what those small white matter changes may be related to. So it's a lot of educating patients and being able as an APC to get a very good and detailed history and making sure I never take for granted anything in the patient chart as far as prior diagnosis. I've been tricked or fooled too many times to just assume anything. So I always want to make sure I'm getting a good history for myself. For me, it's also important in interpreting all of the results, as I know that patients with one autoimmune disease may be at risk for others, that I want to know everything I'm dealing with that individual patient to help lead to treatment, safe and effective and early. Dr. Krieger, looking at some of our evidence to support early treatment, can you please explain different methods of treatment and different schools of thought of how to properly treat patients with MS at diagnosis?
This has been an exciting area of growth in our therapeutic options, but that also makes it more complicated. But it gives us the potential for style, clinical style, whether somebody wants to use high efficacy therapies in MS early, or if they would rather start with gentler medicines and escalate to more potent medicines if that's needed over time. There's a lot of debate in our field as to which of those two approaches is best. I will say, I don't think there's one best strategy for treating MS any more than everybody with MS is the same. They're not. It's a very diverse condition. And I think we have diverse medicines and we can try to apply the strategy for the patient at the right time. So we're going to talk about disease-modifying therapies in more detail in a second podcast in this series. But, the principle of treating early with preventative medicines, or so-called disease-modifying therapies, has been very successful. And I start by telling my patients the goal is to stop the disease where it is, right? To freeze it in time, preventing new lesions, new relapses, and hopefully preventing or certainly delaying disability accumulation deep into the future. I also point out to my patients that our field has moved quickly and that if we can stop or slow down their disease now, and we're going to have more and more options in the future, it helps us to get out in front of it, is the phrase that I use. Hold it in place as we get better and better at treating multiple sclerosis. We talk a lot about shared decision-making in our field, but it really matters. The patient needs to take ownership of their treatment, of their future. They need to not only agree to it, but ideally be enthusiastic about it, because I think that's an empowering way to treat a chronic disease. Allison, you have a lot of experience in counseling patients and talking to them about shared decision-making. I think it's something we're both passionate about. So what are some of the things you take into account when choosing a treatment for a patient and counseling them?
Definitely, I agree. Shared decision-making is something that I'm very passionate about. It's never a good situation when I have a patient who comes in and just tells me, well, you're the provider, pick my medicine. And I have to take a step back and have that discussion that what I may accept for my life is not necessarily something that any individual MS patient would accept for theirs. This may be a patient that has a higher risk of aggressive disease versus someone who has, maybe some milder symptoms at first and recovered very well. So we have discussions there to try to determine early aggressive maybe versus a lower risk therapy. And it's really each patient's individual case to discuss what they accept for safety and risk tolerance and for personal preferences. So given the fact that we have variable modes of administration of the disease-modifying therapies, that really does help in finding something that fits with each patient's preference. I always tell a patient that the most important thing is that it's something that they can make a long-term commitment to and really will fit into their lives. Because if that's not the case, then no matter what is chosen between the patient and the provider, if they don't take it, it's not going to work. I will bring in my thoughts of what treatments may be the best on the table for that individual patient, and then taking into consideration what their goals and long-term life goals even will help to pick the correct medicine at that time. And I say at that time because we're long-term with these patients. So we'll have that discussion in another podcast as well as far as long-term management. But picking the correct therapy at that individual time is very important for the patients. And that really does take a very strong patient-provider relationship. So there's trust each way.
I appreciate that a lot. So, well, I think we've about used up our time for this first podcast in this series. So do you have a one-line take-home that you want people to know about early diagnosis of MS?
I think, take home is it's very important for all providers in any specialty, but also primary care, understand and recognize early signs of MS and getting the patients to a neurologist or MS specialist provider early on for the best care and management long-term. Stephen, thank you for joining me for your shared expertise. We'll continue in the other podcast in this series, which will cover the many treatment options for MS, and we'll also look at strategies for improving long-term management. Thank you to everyone for listening. To claim your credit for participating in this activity, please go to pce.is/MS and complete the post-test. Again, that is pce.is/MS. Thank you.